Benchmark brachial plexus analysis by Colby Johnson. The client being evaluated will be Brady Johnson. The brachial plexus is the network of nerves that send signals from your spinal cord to your shoulder, arm, and hand. Brachial plexus injuries occur when the nerves are stretched, compressed, or in most serious cases, ripped apart or torn away from the spinal cord. Causes of brachial plexus injuries can include contact sports, difficult births, trauma, and tumors and cancer treatments. The client being evaluated experienced a difficult birth where the clavicle bone was broken and the brachial plexus nervous complex was damaged. In the overhead squat assessment anterior view, a compensation that can be noticed is the movement of the knees outward. Probable overactive muscles can include the piriformis, biceps femoris, and TFL/glute min, while the underactive muscles can be the adductor complex, medial hamstrings, and gluteus maximus. For the lateral view, we can see that there is an excessive forward lean in the LPHC, which can be caused by overactive muscles in the abdominal complex, and also underactive muscles in the intrinsic core stabilizers, as well as low back arch, which can be caused by overactive muscles, erector spinae and latissimus dorsi, and the underactive muscles being the glute max. From the posterior view of the overhead squat assessment, we can see an asymmetric weight shift, which is a compensation indicated by overactive muscles, the adductor complex, TFL on the same side of the shift, gastrocnemius, piriformis, biceps femoris, and glute med on the opposite side of the shift, and underactive muscles include glute medius on the same side of. In the upper extremity transitional assessments for horizontal abduction test, the elbow consistently stayed flexed throughout the entirety of the motion in the right arm, which sustained the brachial plexus injury at birth. The potential causes of this compensation can include overactive biceps brachial long head muscle, as well as underactive triceps brachii long head muscle, and underactive rotator cuff muscles, including the subscapularis, supraspinatus, infraspinatus, and teres minor muscles. Although this compensation is seen, it will be later described as why this motion was limited. In the second upper extremity transitional assessment for external rotation of the shoulder, the hand of the brachial plexus side, the right arm, stays far from the wall. This compensation can be caused by overactive subscapularis, pectoralis major, teres major, and latissimus dorsi muscles, and also caused by underactive teres minor and infraspinatus muscles. However, these compensations are not what is causing the lack of range of motion. This will be described later on in the video. For the final upper extremity transitional assessment, internal rotation of the shoulder was tested. For the right arm, which sustained the brachial plexus injury, the hand stays far from the wall, again, just as in external rotation. The causes of this compensation could be overactive teres minor and infraspinatus muscles, and underactive subscapularis and teres major muscles. The immobility of the shoulder has been consistent since birth and sustaining the injury of brachial plexus in the right arm. This leads us to believe that the joint immobilization is actually caused by adhesion and a hypomobile posterior capsule of the shoulder. Lack of shoulder motion is not being caused by any muscle imbalances. In the overhead dumbbell press assessment, the low back arches as well as the elbows stay flexed. The overactive muscles could be the erector spinae and the latissimus dorsi, as well as the biceps brachii, and the underactive muscles could be the intrinsic core stabilizers, as well as the glute max and rotator cuff muscles. The latissimus dorsi does internal and external rotation. The shoulder internal rotation for the brachial plexus side had 36 degrees range of motion, and for internal rotation of the normal side without the brachial plexus injury had 80 degrees of motion. Normal range is 90 degrees. For external rotation, the brachial plexus side had only 8 degrees of external rotation, and the normal side had 74 degrees of motion. The normal range is 90 degrees as well. Of course, this client is not the actual client values, however, they were told to move to the motion of the actual client's range of motion. The erector spinae muscle helps with cervical extension, therefore range of motion was tested for this motion. Normal is 60 degrees and the client had 45 degrees of motion. Cervical side bending was also completed bilaterally for the left and right side. Cervical side bending for the left side was 31 degrees and for the right side it was 36 degrees. Normal range is 45 degrees. Due to the low back arch seen in the overhead squat assessment as well as the transitional assessments for upper extremity and the overhead dumbbell press, it's important to test hip flexion to see how the quads are firing. Since the quads are going to be dominant over the hamstrings, this motion will not be limited and the normal range is 120 degrees. It's also important to test hip extension as this is the motion that the hamstrings will help with. The weak hamstrings will cause a lack in the range of motion of this movement. The normal is 10 degrees, therefore the motion in the hip joint for extension will be less than 10 degrees. Due to overactive quads, the low back arch is caused, therefore when the manual muscle test is done, the rating is a 3. To manually muscle test the hamstrings, the knee will be flexed and the foot externally rotated and they will resist extension. The score on this is a 2, showing that hamstrings are underactive. Trunk extension manual muscle testing showed overactive latissimus dorsi and erector spinae muscles and the score was given a 3. Trunk flexion was given a score of 2, indicating underactive core stabilizers. We use the corrective exercise continuum to help with any neuromusculoskeletal issues that we find in a client. The corrective exercise continuum includes 4 phases. The inhibitory phase, which includes self-myofascial release. The lengthening phase, which includes static stretching and neuromuscular stretching. The activation phase, which includes isolated strengthening and positional isometrics, as well as the integration phase, which includes integrated dynamic movements for holistic. Although the shoulder shows much potential for a corrective exercise program, we are going to focus on the lumbopelvic hip complex for our specific corrective exercise program. For the inhibitory phase of this corrective exercise continuum, we will be focusing on the erector spinae and the latissimus dorsi. To inhibit the overactive quadricep muscles, we are going to do some self-myofascial releasing with a roller on the vastus lateralis, vastus intermedius, vastus medialis, and the rectus femoris quadricep muscles, being sure to get all aspects of the quad. In the inhibition phase, we will self-myofascial release the latissimus dorsi by using a foam roller with the shoulder abducted and moving slightly back and forth on the muscle. Next, we will self-myofascial release the erector spinae muscle by using a lacrosse ball and moving up and down on it against a wall. For the lengthening phase of the corrective exercise continuum, we will be focusing again on the erector spinae and the latissimus dorsi. To lengthen the quads, you're going to pull the knee into flexion and stand on one leg. Pull the foot to the opposite glute of the leg that is being stretched. This will help stretch the quad. In the lengthening phase, we will stretch the latissimus dorsi by crossing the left leg over the right and turning so that the elbow of the right arm is pushing on the knee of the left leg. To stretch the erector spinae muscle, the client should assume prayer pose and move the right hand on top of the left hand to stretch the right side, and the opposite, left hand to the right hand to stretch the left side of the muscle. For the activation phase of this corrective exercise continuum, we will be focusing on the core stabilizers and the glute medius. To do isolated activation of the weak hamstrings, you're going to do a single leg RDL. So you're going to flex the knee slightly and bring the trunk to the ground, touching your hands to the floor. This can be adjusted with added weight if needed. To strengthen the glute medius muscle, the client will be side lying with a resistance band just above the knees. They will abduct the hip, doing a clamshell motion, while keeping the hips stacked on top of each other. To strengthen the core stabilizers, the partner will do lateral rotations of the trunk, holding a medicine ball, touching it to the right and left side of the body, while keeping the rest of the lower body neutral. For the integration phase, we'll be using dynamic movements to strengthen the muscle groups that we're focused on in the activation phase. To strengthen the glutes as well as the core stabilizers, the client will do a glute bridge by placing their feet onto a Bocce ball and moving their hips from flexion into extension while keeping the glutes and the core tight. As well, to strengthen the core and the glutes, the partner will do alternating arm and leg extensions from a starting position of neutral on all fours. This causes the glutes to be squeezed as well as keeping the core tight for balance.